So the role of transplantation in patients with relapsed refractory follicular lymphoma is very controversial. With the availability of highly active novel agent in patients with lymphoid malignancies like PI3 kinase inhibitors, BTK inhibitors, and several novel monoclonal antibodies, it's becoming more challenging to define a subset of patients where transplantation still has a role for patients with relapsed refractory follicular lymphomas. Now, there's high quality data available from the pre-Rituxan era which shows that patients with relapsed follicular lymphoma can have a survival benefit with early application of high-dose therapy and autologous stem cell transplantation. However, key registry studies led by our group at CIBMTR showed that while there is a subset of patients with follicular lymphoma who can have durable remissions with autologous stem cell transplant, the rates of relapse remain unacceptably high. However, the rates of relapse display a clear plateau after allogeneic stem cell transplantation when patients are 1 year out of transplant. So these studies fuel the controversy of autologous versus allogeneic stem cell transplantation in patients with follicular lymphoma. Now, the best method to settle this controversy is a randomized clinical trial, and the Bone Marrow Transplant Clinical Trials Network initiated that key clinical trial that randomized patients with relapsed refractory follicular lymphoma to either an autologous transplant or an allogeneic transplant. Unfortunately, the trial led by Dr. Gina Laporte was discontinued after 3 years because of poor patient accrual. The published results from that prematurely terminated study showed that in the small number of patients randomized on that study, the results favored early allogeneic stem cell transplantation in that setting. Now, to further answer that question, at CIBMTR, our group recently conducted a randomized study where, not a randomized study, but a registry analysis where we compared autologous against allogeneic transplantation following reduced intensity conditionings led by Dr. Evgeny Klinikov from Germany. Our recent analysis restricted to patients treated in the rituximab era showed that either with autologous transplant or allogeneic transplant, there were about 40 to 50% of the patients who were disease-free 5 years after transplantation. An interesting observation of the study was that follicular lymphoma patients who were able to survive for 2 years after a transplant, in that subset of favorable patients, there was a survival benefit in favor of allogeneic transplantation. That recent study done by the LymphoCare group has defined a subgroup of follicular lymphoma patients who have early failure of therapy after Rituxan plus CHOP-like therapies. And that study led by Dr. Carla Casulo shows that follicular lymphoma patients who are failing chemoimmunotherapy early have really poor outcomes. An ongoing study by our group at CIBMTR in collaboration with LymphoCare is comparing autologous transplant versus chemotherapy alone in such high-risk patients, and the very provocative results of this study will be presented at the upcoming ASBMT and EBMT meetings in 2017.